I'm really excited to be here today to talk to you all about a topic that is near and dear to my heart, which is the importance of social relationships, and more specifically, how important your social relationships are in the context of having a pain condition. So, traditionally, and this probably dovetails with what you've all heard today, we've studied pain as an internal process, that there are multiple levels of analysis. We can look, for example, at how problems, say, with a spinal disc, where you may have a herniation or a degeneration, may lead to pinching of the nerves, which then alters systematic functioning that is sent from the spinal cord up through the brain. We look at how once pain hits the brain, there are certain regions of the brain that reliably activate when pain occurs. We look at nerve fibers. There are different nerve fibers that, for example, will detect mechanical pain if you're pinched versus if you burn your hand on a stove. And we look also at how things like neurotransmitters, things that are involved in our mood and our thoughts and our behaviors, but also pain. You've all probably heard some of these terms, serotonin, dopamine, norepinephrine, how all of these things also play a role in both circulating systems in the body, but also pain in the brain. So traditionally, we'd focused on that, but in the last few decades, we've come to understand that the psychology of pain is equally important. That how you think about your pain, how you cope with your pain, and your emotional states make a huge difference, not only in how you experience your pain, but also how you're able to function with it long term. I know that Dr. Darnell talked about this quite a bit in an earlier talk, so I'll spare you hearing the same thing over and over again. But a lot of this comes from what we call the biopsychosocial model. This is the model that we now use that directs both our research and our clinical efforts when it comes to treating people with pain. It's the basic idea that pain is not one simple system. It is caused and altered by a multitude of things that are both biological in nature and psychological in nature. But you'll notice the term is biopsychosocial. We actually, particularly in the last several decades, we've been a little loath to pay attention to how important the social relationships are. And so what I'm going to talk to you about today is not just how your social relationships can be affected by pain, but also how it actually runs a bit deeper than that. There's actually a very intimate relationship between physically painful processes and how we experience social experiences that may actually be painful as well. So we'll start with some obvious points. We know that for people who are dealing with chronic pain, they often experience various forms of social problems that maybe are less prevalent when you don't have a chronic pain condition. So more common social conflict in your relationships, or feeling isolated, simply not being able to do as much. And we know that, for example, not having the same level of satisfaction in your social relationships can come from very basic problems like not having the physical ability or the energy to do the things that you used to do. We also know that these problems can come about because pain can make you irritable, or it can make it so that you don't want to do those things that you used to do that used to be so enjoyable. But also that there's often a deeper problem that can emerge, which is what we call pain is an invisible disease. So in most cases, chronic pain is not something that we can see on the outside. And this is a problem that we hear all the time in the clinic. So people will come in and say, look, I have a lot of people in my life who want to help, but they ask me the same questions over and over again. Just because there's nothing on my body that says that there's something wrong, they don't get it. They don't get what I'm dealing with. And naturally, the response to that might be frustration or anger. And unfortunately, what that also tends to lead to is that people will pull away from their relationships in these cases. The problem with that is that long term, what it does is set up a much higher risk for having physical and psychological problems in the long run. So some of my research at the Stanford Neuroscience and Pain Laboratory has looked at how, for people with high levels of pain, the things that actually tend to predict problems like depression and anger comes not just from sort of how able you are to do things physically, but even more so, the extent to which those things impair your ability to connect to other people. So how satisfied you are with your relationships, how isolated or disconnected you feel from the people around you. So I'm going to stop here and say that this is probably old hat to a number of you. Anybody here with a chronic pain condition is probably thinking, well, of course, pain can be a problem in relationships, if not all the time, then some of the time. But what if I told you that it actually went deeper than that? That it's not just that your pain and your relationships are connected, but that they actually share real estate in the brain. So what I'm going to describe to you now is a series of research that's come out of UCLA in the last 12 to 13 years, and it's very compelling evidence that the brain is wired in a much different way than we have thought for the entirety of science. And the idea is that when we experience things that are socially painful, like being excluded or rejected, the same areas of the brain that light up when we feel physical pain also become active when we experience these socially painful experiences. So to describe sort of what you're seeing on the screen here, this was done with a very basic computer game called Cyberball. Participants would come in and play a game of electronic catch with two other people. And as the game went on, slowly the participant would be included less and less. So the game went from going between 3 people, and slowly it's just the other 2. It turns out the other 2 people in this experiment were actually study staff. They were trained to do this, to exclude every participant who came in. So when that happened, you could see how you might start to feel rejected or left out. And the areas of the brain that light up are the same ones that we see when people experience physical pain, related to emotions and attention and regulation of behavior. Now, for those of you dealing with a pain condition, you might think, well, that's all well and good. This is a single experiment. It turns out the same brain pattern activation patterns rather, are evident in people who've just gone through a romantic breakup or who've lost a loved one. So if you're bereaved, we see these same patterns of activation in the brain. As an additional point, we know that, for example, your inflammatory, your immune system feeds into this as well. So we know that for people who have prolonged social stressors, conflict, being isolated, being in highly stressful work or home environments, they tend to show higher levels of inflammatory activity. So circulating inflammatory markers in your body tend to be higher if you're dealing with higher levels of stress. But what's interesting is in cases where we, for example, inject somebody with a toxin that temporarily increases inflammatory processes, they tend to report being more excluded from these same experiments. So it tends to go both ways. So your pain and your social relationships are they go together hand in hand. So why might this be? There's a prevailing argument. This is a relatively new area of research, but traditionally we've thought of physical pain in its acute form as being a survival mechanism. Acute pain is useful because if we're injured, if we're in danger, if there's some sort of infection, it's important if we're in that danger to get a signal to know that we shouldn't, for example, walk on a broken leg. This allows us to get to a safe place and heal. Dr. Eisenberger and her colleagues have published saying that, you know what, social pain may actually do the same thing. So historically, humans have survived by banding together, by having communities, pooling resources, and providing safety for one another. And it may have been that throughout history, people who have been rejected or kicked out of their societies were probably more at risk for physical danger long term. So that the brain developed to signal danger according to social problems, the same way that it did physical problems. Now, I'm going to stop here and point out that we don't typically think of social pain now as being a terribly useful thing, and particularly in cases of chronic problems. Say if you have long-term problems in your relationship, you are isolated, or you've had long-term issues with trauma or conflict, that those are no longer useful things. Just like chronic physical pain, it's a signal that is no longer telling you anything useful. This is why we want to pay attention to it. Now, to this point, this has been a fairly depressing talk. But there is good news. And that is that just because if relationships go badly, it can make pain worse, it doesn't just go that way. This is very much, there's another side of the coin here. And the other side is that good support, rewarding or supportive relationships, make a huge difference in pain, both acute and chronic. So we know from neuroscience studies and basic psychology studies that if we bring people in and expose them to a painful stimulus, if they have a supportive other in the room, a friend, a family member, a romantic partner, they will report less pain from the same stimulation than if there's nobody in the room. And what seems to be happening is that the areas of the brain that are active when you feel physical pain, they tend to be a little less active. It's actually decreasing that reactivity of the brain to pain or stress. And as Dr. Mackey talked about earlier, our love and pain study that came out of our lab, it turns out you don't even have to have the person in the room If you're looking at a photo of a loved one, that can be enough to get you that same pain-killing effect. So what we think is happening in these cases is that social relationships are a key source of reward, of positive emotions. In the love and pain study, while these people were experiencing painful stimulation, they were also having their brains scanned. So we know that those areas of the brain associated with reward tend to fire up when we see somebody that we care about, that we love. More broadly, this is something that clinicians have focused on in psychology for a long time. We know that people who tend to do better with a chronic pain condition, and this is in terms of having better mood, having better sleep, being able to think more clearly, being able to function better, are the ones who tend to report more positive emotions day to day. And one of the key ways that we get positive emotions is through our social relationships. It's not the only way, but it's the way that we want people to focus on. So I am by trade a resilience researcher. That's what brought me to Stanford. My focus was on looking at what factors might predict how some people with chronic pain actually cope better, how they maintain better quality of life, how they're better able to function even with high levels of pain. And one of the things that I was fortunate to do with a lot of help from our clinicians at the Stanford Pain Management Center was to talk to a group of patients that their clinicians felt were resilient. So we actually had our clinicians nominate people that they were treating that they felt were dealing with their chronic pain in really, really healthy ways. And what I did is if they agreed to talk to me, I asked them questions simply about what is it that makes you different? What is it that makes you resilient? What motivates you? And you'll see about 60 to 70% of the time, what they talked about was other people. You know, that having a responsibility to other people, having motivation to spend quality time, happy time with other people was a key reason that people felt like they were able to be resilient. They also talked about support. You'll see at the bottom, we talk about how my loved ones help me keep things in perspective. So it isn't simply that you are doing things for other people, but that you are in turn getting that same positive benefit back. So, to wrap up, what do we want you to learn from this talk? Just like your physical health matters, your mood and your thoughts matter, your relationships matter too. Not just for your overall health, but for your pain. There's a lot of work left to be done here. But it is important to know that wellness doesn't just come from you as a single person. It comes from you in the context of your family and your workplace and your friendships. All of those things help to promote your health and well-being long-term. It's important in a lot of cases, if you find that it's difficult to engage with people the way that you did, to maintain flexibility, to find ways to do things with others, particularly those that you know you're close to, those that are really supportive of you, to find ways to have positive emotions with them, and to keep communicating. It's a very natural response when things are frustrating, to clam up, to pull away from people. The problem is, in the long term, that can really raise some red flags. It can really cause a lot of problems long term with your health, and it can keep you from engaging with people in the way that you could otherwise do. If you find that this is difficult, it's important to know that you can ask for help. Psychologists have been doing this work for years. This can be done in the context of normal psychotherapy for pain, so cognitive behavioral therapy routinely talks about communication strategies and how to talk about your pain with people in your life. But it can also be done in the context of marriage counseling or family therapy, or if you don't have any of those things available, for those of you who are based in the United States, the American Chronic Pain Association has a number of support groups that are either low cost or free of charge. Okay. There's a lot of ways to get help for these things. And looking at this level of analysis, we think is going to make a very big difference in improving pain care in the future. Thank you very much.
I'm very, very intrigued by your studies. And I love the fact that the physical pain and social pain actually triggers the same part of the brain. My question would be, because we actually are setting up a study with integrated medicine, and the NIH grant is calling for enhanced physical activity, and we want to study the dance therapy through this live video platform. How do you, because there's a multi-level, which means individual with a dance buddy, with a family, with a support group, with other organizations, is there any way that we could track these level improvement based on the social connections without involving a brain MRI scan, because it's hard to execute that in a large group.
So just to make sure I got the question right, in the course of this therapy that you're talking about, you want to track whether or not these enhancements in physical function are improving satisfaction with.
Because there's a data that we're tracking is the pain reduction for these cancer patients that involved in the studies.
Right.
Right now, we're just using the Promise 57, which is quality of life tracking.
Okay.
And there's one dimension, it's just pretty much just surveys, and there's no MRI involved. But I'm kind of curious, especially this particular study funded multi-levels, and it would be really intriguing to actually able to find connections of when the patient involved with a supporting buddy, with other friends and family, with a group, how does that make it stronger in pain reduction compared to when they do it individually?
Well, and at a broad level, I think the expectation is the more that you're able to engage with other people, whether it's with a dance partner, with family, with whoever, that should improve quality of life quite a bit. The social ties tend to have a very robust relationship with how your quality of life is rated. One thing to consider might be to not only get ratings from the patient, but also if you have a romantic partner or family members, to have them rate their quality of interactions as well. So it's important to go both ways.
Did you have them rate what? I didn't miss the part.
The quality of their relationship. So for example, out of the Promise assessments, we actually talk a lot about satisfaction with social roles and activities. This is another domain that could be pulled out and maybe used for that purpose.
Okay. Thank you.
We have a question all the way over on the left.
So in the beginning, you talked about the frustration of explaining to your loved ones and friends your pain that's on the inside. And the only way I've been able to do it is come up with like a number system on a scale of 1 to 10. Okay, it's a 6. Anything above a 6, honey, I got to go home. But have you seen in your research or anything that there's a better way to explain or help your loved ones understand what you're going through without, these complicated mathematical.
Yeah, and it turns out to be what everybody's least favorite type of assessment, right, is please rate your pain on a scale of 0 to 10. Everybody loves that, right? The answer I can give you honestly is that, just like everything else that we talk about, there's a huge degree of variability in how people navigate these things. When it comes to relationships, because it doesn't just involve one person anymore, there is no one clear-cut way. If you and your loved ones find that this is an effective way to communicate about it, if it feels like it helps us get on the same page, even though they can't tell when I'm at a 6 or a 7 or an 8, if I can tell them I'm at a 6, I gotta go, it's a lot better than saying, well, you look fine. Isn't that? The answer to that is if that's something that has worked out better for you, it's perfectly reasonable to do that. When we treat these things in sort of a therapy setting, the focus is on finding a way for it to be workable. There is no one-size-fits-all communication strategy. If it works for you, then that's what we want.
I'm glad that you spoke about inflammation and how inflammation can impact pain. And I was wondering if the Pain Center, the Stanford Pain Center, has rheumatologists working there. And why is it that inflammation makes pain more pronounced, or kind of what you touched on earlier?
As far as I know, we don't have anybody who's strictly a rheumatologist working at the Pain Management Center. The broader answer, and I am not by nature an immunologist, I'm a psychologist, but it's something that we've gotten to be very fond of. The discussion of inflammation tends to be, for a psychologist, that whenever you experience stress or pain, there are normal circulating changes in your inflammation that will come with that. So in much the same way that if you're stressed out, your inflammation markers may actually increase. If you engage in more positive emotions, you have more of a relaxed state, it will go back down. These are normal circulating processes. Now, the broader level of what you're asking, of treating inflammation, I'm going to shy away from answering too much. I'm not an MD. I don't want to step on anybody's toes here. The answer to that is that generally, my understanding is the clinicians do consider that. So, there are certainly anti-inflammatory therapies that are done along with the psychological and physical therapy modalities that you've heard about.
Great. We're going to just very briefly cut off this part of the Q&A. We're going to pause, You can keep your hands ready to go back up, but we're now going to invite everybody back out who was giving presentations for the afternoon session. And thank you for, let's give Dr. Sturgeon a warm welcome, a warm thank you.